are actually doing some questions.
So how long is the presentation? Is 20 minutes or 15 minutes? Or
20 minutes or so, yes.
minutes?
Okay, let's see. Let's look for Salman. I saw him just a little minute ago here.
So Mohammed is talking first. I didn't cover at all, almost at all, the subject of craniopharyngiomas. I just have one slide or two slides on craniopharyngiomas. So because I knew that he was talking about that. So
Sure.
And I'm not covering at all the transnasal, the endonasal approach, because I thought that he would have also covered as well. So I'm just a pure interhemispheric, purely interhemispheric, and endoscopic transforaminal.
Yeah, I am actually mainly covering the pterional approach and endoscopic transventricular.
Okay.
No endonasal.
Okay. But it should be 20 minutes is not so much, right? It is a lot to say, but to cover completely well a subject is not finally is not so much.
So you can extend a little bit. We have around 1.5 hours, so we can, extend if needed, and then some questions will follow from the audience.
Sure.
So don't feel that pressed with time. Okay. So let's look for Salman. Let me text Salman. Okay, so Salman is just joining now. So let's wait for him. Oh, there he is.
Hi guys, how are you?
Hi, Salman.
Hi, Salman. How are you doing?
Not too bad. How's life? Mama, good to see you.
Yeah, nice seeing you, Salman.
It's a pleasure. How's it going, Pepe? What are you guys doing? Are you increasing the numbers again?
Yes. In Naples, yes. Naples area is the worst in Italy in the last week. So we are facing a bad second wave. But fortunately, with the mortality rate that is much lower if compared, like in the rest of the world.
Yeah, I think it's overall much better. The rates are again going back, but as you say, thank God that the mortality is really low everywhere.
Yeah. I will announce next week that the workshop in January has been cancelled, because with the last numbers, it's just crazy that I started to organize now such a huge thing. I'm very sorry about that. I will call starts first, and then I will give an official announcement to all of you. But you can cancel those days from your calendar. I'm really sorry. I don't want to transform this in a smaller or a webinar or it's because it is expensive. I have to talk to Georgia first. I will talk also to Henry, but for the moment I will remain like that.
Okay, brilliant. For the participants, the pre-quiz is on. Can you please go on the link and just solve the pre-quiz quickly so we can start? It's Pepe and Mohammed, it's really our pleasure. Adrian has done a wonderful job by organizing these webinars for ISPN, and we're really enjoying these talks. And I think the most important bit that I feel when I was a trainee, if I was not going to go and work in pediatric neurosurgery for a year and a half, and if I've not seen all these cases, and to hear all this from experts is unbelievable. It's really mind-boggling. Amazing talks.
Okay, so
Thanks,
shall we
Adrian.
start?
Thank
Yes, I
you.
think we're all set to go.
Okay. All right. So good morning, good afternoon, and good evening, friends from all over the world. We are continuing with this series of sessions on pediatric neurosurgery. Today we have, we're very lucky to have two giants in pediatric neurosurgery, Professor Mohammed El-Beltaghi and Professor Giuseppe Scinali. First, we're going to start with Professor Mohammed El-Beltaghi, which, as you know, is a professor of neurological surgery that graduated from Cairo University in Egypt. He is the head of the Department of Neurosurgery at the Children's Cancer Hospital in Egypt, 57357, which is an enormous operation for pediatric neurosurgery in the northern part of Africa. It's a worthwhile visiting center. They have an extensive accumulation of oncology cases. So without further delay, we'll proceed to hear Professor Beltaghi discussion on the management of craniopharyngioma. Please, Mohammed.
Yeah, thank you, Adrian. And it's a pleasure to be with you in this prestigious webinar. Start sharing my screen. Can you see my screen now?
Yes.
Yes. Okay. So to start with, I will be focusing on the management of pediatric craniopharyngiomas, surgery mainly. As an introduction, the craniopharyngioma is a very challenging pediatric brain tumor, which represents 3 to 4% of the childhood tumors. And the presentations are variable, but most of the children, when we see them, they come with an increased intracranial pressure. Some little older children come with visual affection because the children do not complain usually of visual affection except lately in age, and some endocrine and hypothalamic manifestations at their first presentation. In the pathological difference between the craniopharyngioma in adult and pediatric, we can have that in pediatric, it's adamantinomatous type, while in the adult, it's a papilla type more common. The origin is differently coming from the epithelial remnants of the craniopharyngeal ducts of Raschke's pouch, and genetically, there is a mutation in the beta-catenin of the Wnt signaling pathway, which is whenever you find that there is an aberrant or a mutated beta-catenin, this has a reflection on the prognosis with a more aggressive type of a craniopharyngioma recurring mostly, while in adult, it's mainly the BRAF genetic difference. Usually in the management of the craniopharyngioma in children, it varies from adult that you have a complex balance between the quality of life, the tumor control. When you choose to have an optimal strategy of management, it's usually a matter of debate between you totally remove the tumor or you just subtotally remove it and give an adjuvant therapy, because this would matter in the quality of life of these growing kids. On the other hand, in adults, they can play differently and you can still have some conservative managements easier than in children. When you find such pictures of craniopharyngioma in children, they completely differ in their management, which makes the management surgically individualized, which means that when you approach a craniopharyngioma in a child, there's a single mandatory approach that you can take. You have to treat each case separately and individualized according to the picture, the presentation, hypothalamic manifestation, the vision, and the age of the child. We have just recently published a management protocol from our high flow center with 137 cases. where we prescribed the protocol of management of these cases. When we started in the first 50 cases is completely different when we ended in the last 50 cases after seeing the outcome and the quality of life of such children. Also, we published in May this year the protocol of management in a low and middle income settings when according to the CIOPC adapted treatment guidelines. So craniopharyngioma in children, again, the quality of life matters, especially with long life expectancy and benign nature of that tumor, the age and the growth of maturity. So you have these children growing, he has to go to school and you have to follow him up for many years. We need to have a good quality of life. The handicapping effect of hypothalamic manipulation and pituitary dysfunction would endanger his quality of life. And of course, a prolonged learning curve. The more recurrences with more adhesions and morbidities, you see the child having recurring craniopharyngioma, which could be always difficultly managed than the de novo ones. We started gross total resection versus near total resection, and subtotal resection leaving less than 1.5 centimeter and giving radiation. Some cases with purely cystic, we just insert an omaya and take a biopsy with starting radiation therapy, and some heavily calcified lesions, we follow them up without any intervention. The maximum possible excision and adjuvant therapy for a residual, and the conservative surgery and adjuvant therapy. This is the debate of managing protocols. What does a conservative surgery concept in a craniopharyngioma means? It doesn't subtotal lesion at all. It's based mainly on your intraoperative assessment of the lesion, as well as the radiological appearance of the lesion before the surgery, and maximum safe resection possible intraoperative assessed, and this could be aided by the endoscopic assistance in the surgery when we are going transcranial. We have a gross total resection where the goal is totally removing safely the lesion whenever it is dissectable from the hypothalamus. Whenever you find it attached to the hypothalamus, which could be assessed intraoperatively and preoperatively by the imaging, leave intentionally the least possible residue to the hypothalamus, and whenever we start using with no or a small solid, we can still insert endoscopic or stereotactic or open omaya and start adjuvant therapy or conservative. So again, the concept is greatly aided by the neuroendoscopy, visualization of unrecognized parts in corners, helpful, careful, non-blind dissection of the tumor from critical neurovascular surrounding structures, extent of resection as much as safe as possible, aiming at total or near total safe resection. When we have progression or a recurrence, we have to minimize this recurrence, preserve the hypothalamo-pituitary axis, and preserve the quality of life. Again, this should be individualized and model, which is a teamwork using your endocrinologist and radiotherapist and a combined clinic with tumor board to get the maximum benefit to the child. To start with some cases as how we approach the craniopharyngioma. As a case, we can approach it in a right pterional approach. Usually, I do them pterional approach. We go right if the vision is equally affected on both sides, or is it normal, or I go on the affected side of the optic nerve, which means if it is affected mainly on the right, then I go right, if left, then I go left. And this is how we fix the pins and the Mayfield and the pterional approach as described by Yashergil. Then going intraoperatively, start opening the chiasmatic cistern, then the carotid cistern, and releasing CSF first to start creating spaces. As you can see, that's the right frontal loop, right temporal loop, retraction, opening the sylvian fissure from in back, That's the right optic nerve, the right carotid nerve. Sharp dissection. Again, creating planes between the right and the left optic nerve. And here, opticocarotid triangle, that's the posterior communicating artery. We usually try to find this all over in all triangles in order to dissect safely from all structures and sharply. You can see that all through, I'm trying to dissect the tumor from opticocarotid and interoptic, and now from the carotid oculomotor, that's the oculomotor, the carotid, inserting cotinoid in each space I gain, and sharply dissecting around the tumor. That's the opposite carotid artery on the left side. And then getting the tumor from the largest space possible without endangering the optic nerve or the vessels. You can see it can work from spaces in order to get it dissected and easily removed. And this could be possible when you work in all planes and see all the vital structures. Removing that doesn't mean that you still have removed everything. I still have some solid parts here where we work from the carotid oculomotor triangle, getting the rest of the tumor in pieces. And then that's how I introduce the endoscope, 0 and first, from the terional approach. I'll show you the picture, but this is how you use the endoscope with the microscope. One hand, the endoscope, one hand, the suction tube. And I can still introduce it from all sides, all triangles, and see if there is something left, and I could remove it, either microscopically again, or endoscopically. And finally, introducing the endoscope after assuming total removal, we now assume total, introduce the endoscope, where we can see that there is a small residual underneath the optic chiasm here that was not yet removed and not visualized by the microscope, and start removing it sharply with pulling chiasm, endoscopic assisted. This is how we use the endoscope assistance in the terional approach. This is another case which I also want to show you. This is the images preoperatively in a 13-year-old with visual affection, and profile was normal. The same way, right frontal, right temporal lobe, dissection in all planes, all triangles. This is the right carotid, the right optic nerve, the left optic nerve. You can see here the space in between the optic is completely different. It's too small because this is a prefixed chiasm, not like the other one. So you don't have many space to work in. And in such case, we just start moving it pieces and not like the previous one in one piece. That's introduced the endoscope very early to see if there is attachment of the tumor, where we go down to the fourth cranial nerve and to the basilar artery. Here, the fourth cranial nerve, the basilar, the liliquist, and you can start removing the tumor in pieces, not in like this one, because the spaces are too small. You can see it sharply cutting and removing it piece by piece. and in always introducing the endoscope to see if there is any residual or to dissect. In this special case, because the triangles are small, we got the rest of the tumor here. You can see the optic nerve is very small. When I introduce the endoscope, that's the underneath of the optic. There is an injury in the underneath of the optic nerve by getting this part. Fortunately, he had a good vision, but with a field defect because of this underlying injury. So that's the pituitary stalk, and that's a remnant of the capsule. And again, you have to ensure good hemostasis and give long time for the hemostasis, just irrigating and waiting and raising the blood pressure, because the development of a post-operative hematoma in craniopharyngioma is really very bad in its management and its prognosis. That's the after 3 years, and you can see that there is a control of the tumor without radiation. In case of such large craniopharyngiomas in a 7-year-old female presented with increased ICP and visual deterioration, we can treat them or just open surgery. In this special case, because of the midline shift, we started open surgery. And this was a good decision because the wall of the cyst, as you can see, is totally calcified. This is a left pterional approach. You can identify the vessels, the vascular tree, or the optic nerve from the start. As you can see here, I started identifying the optic nerve as first in order to protect it by a cottonoid, and then I start sharp dissecting the wall of the tumor sharply from the vascular tree in order to remove the calcified wall with preservation of the vessels and the optic nerve. That's the left carotid, and that's the bifurcation. As you can see, all is disrupted by this heavily calcified wall, the optic nerve here underneath, and we continued sharp dissection and removing the wall of the tumor completely without inserting any omias and then hemostasis. As you can see, that's the immediate follow-up complete. Later on, he developed recurrence, and we did again surgery and radiotherapy because of this recurrence. This is another case. Left side was the approach, left pterional, because we have vision affected on the left side. This is the left frontal lobe, left temporal lobe, same way, in the optical triangle, starting removing pieces of the tumor, introducing the endoscope early. That's the pituitary stalk, and that's the tumor. In this way, we start endoscopic assisting. You can see I gave the endoscope to my assistant holding it, and I work by both hands, the suction tube and the dissection. In the other hand, removing the part attached to the stalk and removing the parts attached to the liquid membrane. And then in cases, that's the endoscopic visualization after excision. You can go down, see that after opening the liquid membrane, that's the basilar artery, perforators, the brainstem underneath, and remnant of the capsule attached to the pituitary stalk. That's how it looks like when you watch by the endoscope. What about such heavily calcified tumor when you see a bunch of calcium in this supracellular area in a 7-year-old and having visual affection? That's, you went again here, same approach, pterional approach, right? That's the optic carotid. In such case, we were lucky have this white space that we can dissect sharply between the heavy calcified tumor and the left optic and the carotid, and here from underneath the opticocarotid triangle, dissecting again the calcium. Manipulation of this should be careful because you are very vulnerable to cut the perforators or to injure the underneath of the optic chiasm where the main blood supply of the optic nerves come from. And this could endanger the vision. So you have to be very careful in manipulating. You can see inserted a piece of cotton underneath the optic while dissecting in order to protect the optic nerve from this calcium, which cannot be fragmented in place. The only way is to get it outside as one piece. And this happens by working again through all spaces and sharply removing until getting it as one piece, pushing away from the optic and not toward the optic nerve, not to injure again the optic nerve, and removing it. And then introducing the endoscope from this wide, this is a prefixed chiasm. You can introduce the endoscope post-fixed chiasm. Introducing the endoscope here, you can see I put it in the opticocarotid, then put it from the interoptic. You can have, that's how you introduce your endoscope to check all the parts. That's the endoscope, the Storrs one. I introduce it like this way, holding it in my hand. This is just an inspection. So with one hand and the suction sometimes with the other hand, and looking through the endoscope monitor where we can see this picture. That's the introduction of the endoscope. You can see the pituitary stalk, the dorsally, the optic chiasm, and you can check for any residual. That's the basilar down here. Again, basilar artery, stalk above is preserved. This is checking by the endoscope, the two optics, the carotid and the underneath. I usually use both the 0 and the 30 degrees to check all the corners. And that's the post-operative. So again, when we mention conservative management, we mean that leaving a small part like this would be helpful for the quality of the patient. And this part, as you can see, is attached to the hypothalamus, left behind in this case, although it's cystic, but the wall is attached to the hypothalamus. And this is 3-year and 6-year follow-up after radiation. This is another case, leaving the wall attached to the hypothalamus and following up 3-year, 5-year, and even more. What about such huge cystic part, which you have temporal cyst and CP angle cysts? What would we approach, or how could we approach such tumor with this huge cyst? Should we go or tunnel? So I went again in the left pterional approach. Again, I just highlight the endoscopic assistance in such case. Here I will first this concept: left pterional, optic nerve, left carotid, dissecting around again interoptic, and all spaces, then remove the large part tumor from the large space created. Here is the carotid oculomotor. Some of the cases, as a complication, we get temporary oculomotor palsy that resolves within 3 months when concussion of the oculomotor. Here, I went again, you can see the 7th, 8th nerve, the 6th abducent nerve, and down to the CP angle to check this, the 5th nerve, and then remove the rest of the wall of the cyst. getting it from the CT angle. This was the help of the endoscope assistance to get the whole tumor out from the terional. And going by the endoscope, that's the 7th, 8th in the meatus, the 5th, that's the 6th cranial nerve. And you can check for hemostasis, you can check for any residual in the CT angle, this all through the terional approach. And that's the post-operative images. So what about cystic craniopharyngiomas? When we have a pure cystic pharyngioma like this, I just went through a right Kocher burr hole, puncture the cyst, and take some biopsies for confirmation. And then I insert an endoscopic guided Ommaya through the terional, as you can see, this is the Ommaya inserted. And that's all, 15-minute surgery, and then you can get that post-operative. When we did an MRI, you can see that there is a small solid part that just could be follow-up or radiotherapy. Another case, which is a cystic, completely cystic, and the small solid part is seen. So we just went the same way, Kocher, puncture the cyst, take a biopsies, and then insert an Ommaya. And in this case, I did third ventriculostomy also. And operatively, that's the third ventriculostomy down to the basilar. And the post-operative, you see Ommaya, complete resolution of the cyst, and there is a very small solid part that could be followed up or receive radiation therapy. So that's how we approach craniopharyngiomas, and I didn't mention the beta-catenin at the beginning. It is a cytoplasmic protein that mediates the gene transcription and cell-cell adhesion, activating mutation in the gene encoding beta-catenin identified in the childhood adamantinomatous craniopharyngioma. This signaling pathway, when it is apparent, they have rated and aggressive. So there are some craniopharyngiomas that you remove and you have them recurring even after total excision, and there are some which you just remove and you have them controlled, which means that there is a mutation in this genetic pathway, and this could help in future treatment. We assessed the 102 cases. We find that positive expression was in 68 cases, which may point for a great in the pathogenicity. And the 5-year progression-free survival for beta-catenin preserved case was 65.5, while the 5-year progression survival for the apparent were 39.4, which got us to that even if you totally excise this craniopharyngioma and have an apparent beta-catenin above 10%, it's better to give radiation therapy. So that's a proposed algorithm for the treatment of a craniopharyngoma. When you have a new patient with a craniopharyngioma, manifestation of hydrocephalus, if it is emergency, do a shunt. This patient is stable, you just have cystic part or completely cystic, huge cyst, do it stereotactic and put in Ommaya and then radiation. If the cyst is large and you can get through the ventricle, get the endoscopic Ommaya and biopsy or open Ommaya. All this, if the small solid part is less than 1 centimeter, just go radiation or up. If you have mixed solid and cystic, then open surgery, intraoperative assessment for resectability from the hypothalamus together with endoscopic assessment. Hypothalamic invasion, then go for subtotal, near total, and then radiation. Completely not invading the hypothalamus, then go for gross total resection, and then check for beta-catenin again. If it's positive, then go for radiation. If negative, just follow. Craniopharyngioma is a highly challenging pediatric tumor, age group very precise, and wise decisions should be always taken intraoperatively. The concept of conservative surgery must be kept in mind, which does not mean biopsy, but just conservative surgery means maximum safe debulking. In case of the preserved endocrine hypothalamus function, try to keep them preserved. Near total or partial resection followed by radiation could be accepted as a less surgical attitude in case of hypothalamic invasion. Only assume radical resection. There is hypothalamic invasion is to have some beautiful pictures of the kids while they have aggressive behavior, poor school performance, obese, stunted growth. All this will be on a long life term. So preservation of function is your target and not a good images. In selected cases, some cases, repeated minor interventions may be adopted to decompress the optic apparatus and manage hydrocephalus. The multimodal progression is a must and should be tailored and individualized, which should be a teamwork with your endocrinologist, oncologist, and radiologist. Thank you.
That was a brilliant lecture, Mohammed. You have extended experience with these lesions. I think we will hold the questions for the last part of the seminar. And now we will proceed with Professor Shinali, which, as you know, Professor Shinali has been a fundamental piece in the old ISNG, then at the IFNE, which is the International Federation of Neuroendoscopy, one of the past presidents. And is a very important figure at the European and International Society of Pediatric Neurosurgery. He is now the head of the Department of Pediatric Neurosurgery at the Santo Bono Posillipo Children's Hospitals in Naples, Italy. So without further delay, I will give the presentation to Professor Shinali. Please proceed.
Thank you very much, Adrian. Fantastic lecture from Mohammed. And thank you for the honor of being invited to the seminar of the ISPN. And I will address mainly the midline interhemispheric approaches to the third ventricle. From the very classical slide and figure that was shown by Roton, we know that the third ventricle can be approached in many ways, of course, since it is in a structure that is in the very middle of the brain. So we will just analyze slowly all the possible approaches, taking some time more on the interhemispheric approaches. He divided the third ventricle in three main parts, one anterior, one superior-posterior, and one posterior-inferior. And according to these three main parts, he was suggesting different kind of approaches. The anterior approaches, we will start by citing, of course, the endonasal approach. It is not part of this webinar because so many webinars have been done of endonasal surgery, but and I'm not personally doing this kind of surgery. I share this my patient with the Professor Capabianca, who has a very extensive experience in craniopharyngioma and the third ventricle tumor removal through the endonasal approach. We only have to remember that this is the very first and most anterior approach. Through the nose, we can remove even very large tumors that are inside the third ventricle, mainly craniopharyngiomas, and this should be really considered as one of the most important approaches of the to the third ventricle, especially in the management of craniopharyngiomas, both in children and in adults. This video is kindly offered by Professor Capabianca. You can see that at the end of a craniopharyngioma removal, you can have a very nice vision of the whole cavity of the third ventricle with this is the tumor removed, the stalk is preserved, and you can see the trigon and the tela chorioidea and the massa intermedia. So this is definitely the most anterior and probably the less invasive approach to the third ventricle. And this is the pre-op and post-op to show that even very large tumor lying mainly into the third ventricle can be removed through the nose. In pediatric practice, when we have, for example, this is not a really third ventricle tumor, but this is a chemo-resistant OPG progressing under chemo, and you can see that a very large part of this tumor is lying where the third ventricle should be. So in this kind of cases, for example, another kind of approach is requested. You can do nothing through the nose, of course, because they are frequently very small babies in the first 2 years of life. And so we have to deal with the interhemispheric translaminar terminalis approach. On the old figures of this approach shown on the surgical atlas, this is mainly considered as a unilateral approach, but in my practice, you know, only doing a small unilateral craniotomy and dissecting unilaterally the interhemispheric fissure to arrive to the lamina terminalis. In my practice, to have better vision, and since we need to have the best possible vision also of the upper part of the third ventricle, we need to be very low with the bone resection at this level and frequently removing also the orbital bandeau. I prefer to have a bilateral craniotomy, cutting completely the folks, and to have a real bilateral complete exposure of the interhemispheric corridor. For example, in this case, this is the video of this case. You can see that we have removed and coagulated the folks. We are cutting the lower part of the folks in the depth of the interhemispheric fissure, and you can see that the folks can be quite tricky to follow until the very, very last part. And after cutting the last part of the folks, we can expose very nicely the anterior pole of the tumor, and we can follow the tumor through the main axis of the tumor. We are opening the anterior capsule of the tumor, and after opening, of course, we can do the biopsy and do the internal debulking of the tumor. And this is the post-operative MRI of these cases. You know that OPG should not be removed completely. In these cases, they have to be managed conservatively as much as possible before radiotherapy, and then bring the patient to the radiotherapy until with the smallest possible target to irradiate. And then this patient, after conformational radiotherapy, was finally free of tumor for almost 6 years and recurred only 6 years after radiotherapy. So this is a combined approach, and surgery has a very important role. In other cases, when the lateral diameter is almost as large as the anterior, anteroposterior diameter, I still prefer to have the anteroposterior corridor, because with a bilateral approach, I can have a very nice control also of the most lateral parts. Of course, either terrenal or the subfrontal approach are valid in these cases, but in this case, I still prefer the anterior interhemispheric approach. I need to remove as much bone as possible below, because I need to have the better control. We know that there is this part that is clearly created by the anterior communicating artery, and behind the anterior communicating artery there is a large part of the tumor that is not visible even if we remove very low the middle orbital bandeau. So in this case, of course, there is a black area that is not visible with the microscope, and in this case, of course, the help of the endoscope is very important, as brilliantly shown by Mohammed with the use of craniopharyngioma. This is another OPG, and this is, of course, a very important position of the screen of the video of the endoscopy in order to be able to see contemporary through the endoscope and through the microscope. And here you see the black spot that is very nicely seen through the endoscope. Here you see the residual tumor lying below and posterior to the anterior communicating artery, and we can remove it under endoscopic control through with a vision that is absolutely impossible to obtain with the microscope. And you can see how easy it is under endoscopic control to remove completely the part that is hidden. And you can see that even the part relying into the third ventricle is completely removed without visual compromise, because here the optic pathways were lying very, very low, and this was mainly a greatly exophytic part of optic pathways gliomas. Another anterior approach that is rarely considered is the anterior interhemispheric subrostral translaminar terminalis approach. I do this very, very rarely in the very rare lesions that are completely anterior to the foramen of Monroe and completely hidden behind the anterior commissure. Here you can see this is secreting teratoma that was regrowing after an initial chemotherapy. It was secreting beta-HCG, and here you can see that the foramen of Monro is here, and the tumor is completely anterior and hidden, and this is the anterior commissure. So in this case, certainly the subrostral approach could be very interesting, especially because we have a very large window. This operative window is given by the two fixed points that are the lower profile of the rostrum of the corpus callosum and the anterior communicating artery. All the area between these two parts is a surgical corridor, and in this case it is very, very large, and through this very large surgical corridor we can approach both the upper pole of the tumor and the lower pole of the tumor, and it is certainly it is a very long interhemispheric dissection, can be quite tricky in small babies, but at the end of this dissection we can see very nicely the two pericallosal before they turn and go up to the corpus callosum. This is the, we protect one pericallosal artery with one cottonoid, and here we can see the lamina terminalis and the tumor below the lamina terminalis stretched by the tumor, and here we are retracting the other pericallosal artery, and we can see, and after a very, very long dissection, it was a very thick and hard teratoma, we are able to make a complete removal, and this is to show the nice vision that through this approach we can have of the third ventricle. And this is the post-operative MRI with a complete removal of this secreting teratoma that went to radiotherapy after our removal. And now we go to the anterior transcallosal, the standard royal way to the lateral ventricle and through the third ventricle. This approach is done with the head straight and elevated 20 degrees. It is very important to me to have a very important elevation in order to be comfortable with my hands and with my back and with the line of sight of the microscope. The scalp incision is a coronal skin incision, longer on the right side. The curvilinear incision should be behind the coronal suture. We can discuss for hours about the flap. Some like the triangular flap, some like the square flap that crosses the midline to check and to see well the midline and the sagittal sinus. So, but basically we need to see the sagittal sinus, and we don't have to have any obstacle in the line of sight due to bone on the midline. So please do the best, the bone flap that you prefer, but please, you have to see the lateral edge of the sagittal sinus. Then you can open the dura. You can do it in a C fashion or like this, or you can do in a cruciform fashion, whatever you like. I prefer personally the cruciform fashion. And then you have to deal, after opening of the dura, with the cortical veins. Cortical veins, normally there is always one or two cortical veins in your site when you do your bone incision above the coronal suture. And of course, one of these cortical veins sometimes requires to be coagulated, and you can do this with impunity. If you check how is the pattern of a venous drainage in the normal brain, you see that there is a very huge parietal collector, Rolandic collector, and a very huge frontopolar collector, but in the area that is exposed by our flap, by our bone flap, finally the cortical vein is very small and can be sacrificed with impunity in order to have easier access to the interhemispheric fissure. And now the dissection of the interhemispheric fissure, this is how we do an alternance of old videos and better videos and more modern videos. You can open the pericallosal system. This is an ideal case, just a mild retraction of the hemisphere. You find a beautiful pericallosal system, and this is very easy to do the transcallosal in this way, and this is very nice. You find immediately the two pericallosal, and you can see very nice the corpus callosum. It is not always like that. At this time, you can open the pericallosal cistern. Of course, there is an arachnoid covering the two pericallosal artery, and this is the part of opening of the pericallosal cistern, and that is covering the two pericallosal artery. It is not always so evident. After clearly identifying the pericallosal cistern, then you have to put another retractor on the falx in order to have more vision. And the second, the left hemisphere is protected by the falx. At this point, we progress, and we must know, especially in children, especially in cases with a long-standing chronic hydrocephalus, there can be very significant adhesion between the cingulate gyri. Our anatomical landmarks here is the lower edge of the falx. We must know that the falx does not arrive frequently down to the pericallosal cistern. Sometimes it can stop up to 1 centimeter above the pericallosal arteries. So we must know that finding the lower edge of the falx is not the end of our dissection of interhemispheric fissure. We must know that because after the lower edge of the falx, we can have cingulate gyri. This cingulate gyri, like in this case, can be incredibly adherent one to the other, especially in cases of chronic hydrocephalus, in tumors creating chronic hydrocephalus. So we must know that we must dissect very carefully the two cingulate gyri that are cortex that is highly sensitive and involved in the memory circuit. So we must know that below the cingulate gyri we will find an artery, and we must know that this is the callosomarginal artery. It's not necessarily the pericallosal artery that we can find only at the very, very final step after opening finally the pericallosal cistern. So these are all tricky points of the interhemispheric fissure approach for the transcallosal approach. We must know that, because if we do not know that, we risk severe damage to the cingulate gyri, and we can account for most of the memory troubles that we have after interhemispheric approach. So we can dissect the cingulate gyri. Here we see a case where the cingulate gyri are very, very adherent to each other. After high magnification, we find some artery, we open some arachnoid, we think that we are into the transcallosal cistern already, but in fact, it is not really like that. We see the callosomarginal artery, we protect a little bit better our hemisphere, and we need to understand a little bit better. This is an artery, but we could think that this is the pericallosal, but this is not the pericallosal. This is the callosomarginal, and we must dissect beyond the callosomarginal, and we have to be very careful in this dissection, because below the callosomarginal there are the kissing cingulate gyri, and we must dissect the cingulate gyri very carefully. See how adherent are the two cingulate gyri, and see how close we are to the callosomarginal. Here you can see the adhesion between the cingulate gyri, very, very adherent one to each other. This is especially frequent in tumor of young adolescent who harbor third ventricle tumor, low-grade tumor for many, many months. And this is the final part of the section of cingulate gyri. Here you can see that you even have some small bleedings from the small artery, cortical artery of the cingulate gyri. You see how tight they are and how careful I am in trying to protect as much as possible the cingulate gyri. And finally, we can find the arachnoid of the pericallosal cistern. And finally, after the end of this very long and painful and careful dissection, I can find the pericallosal cistern, and your reward is, of course, the two pericallosal artery. Here we are at the very end of the dissection. This is the callosomarginal the other way, and finally, I will discover the two pericallosal lying below the final and the lowest part of the cingulate gyri. And this is the white ivory color of the corpus callosum, to not misunderstood with the cingulate gyri. Dissecting the interhemispheric fissure with the Epstein forceps, that are by far the best instrument to dissect in a equal way on the right side and on the left side. Fantastic instrument created by Fred Epstein, very, very nice instrument. And now finally we have our corpus callosum and we can proceed to the callosotomy and to the incision of the corpus callosum. It's better to put some patties in the interhemispheric fissures because in this way we keep our interhemispheric fissure wide and we can limit the strength of our retractors. Anterior patty is very important in order to stop the oozing into the surgical bed of some blood from the interhemispheric fissure. Then at this time we have to load and protect the pericallosal arteries before incising the corpus callosum. Here we are loading the pericallosal artery on one side and on the other side. And now we are ready for our callosotomy. The callosotomy is a midline 2-3 centimeter incision between the two pericallosal arteries by bipolar cautery and suction. We have to be careful about the anatomical variation of the pericallosal artery. We need to see very nicely the white ivory color of the corpus callosum. This is another dissection of the interhemispheric fissure with the cingulate gyri that are very, very adherent. You can see very nicely the two cingulate gyri at this level, very adherent and a little bit hard to dissect. They are not completely separated and the dissection can be sometimes traumatic, but finally at the very end of the dissection you have your reward and you have the white ivory color of the corpus callosum and the two pericallosal artery, and you can see very nicely the two pericallosal artery. And here we are ready for the, you can see the bright shining ivory color of the corpus callosum, and we started the incision of the corpus callosum with the retractor or with the cautery and with the suction, and we can use any instrument you want, and then you progress with your retractor into the corpus callosum and into the ventricle in order to see the lateral ventricle. Sometimes you have to be careful about that, because if the cavus septum pellucidum is entered, no ventricular structures are seen. In this case, for example, you can see that you see in the very middle the line of the septum pellucidum, and you have to be careful to choose the proper ventricular cavity where to enter. It's very easy to enter into the contralateral ventricle if you don't pay attention to the septum pellucidum. Then exploring the lateral ventricle, septum pellucidum may bulge into the surgeon's view, so sometimes it is necessary to perform a 1 centimeter incision of the septum pellucidum, decompressing of the contralateral ventricle, and in order also to access both Monro foramina. At this time we are into the lateral ventricle. We have several operative corridors to the third ventricle. We have the transforaminal, interfornicial, and subchoroidal. Transforaminal, of course, is indicated if the Monro foramen is dilated by tumor of hydrocephalus. In this case, for example, low-grade glioma of the third ventricle. We can see after entering into the lateral ventricle the Monro foramen that is occupied completely by the tumor. We dissect the tumor from the anterior column of the fornix, and we after dissecting we can remove quite easily only with the cavitron, do the internal decompression of the tumor, and we can see at the very end of the surgery the floor of the third ventricle and the tuber cinereum after complete removal of the tumor, and this is the postoperative. When you have suspicion that your tumor is lying also on the other part, here you can open the septum and cross the midline and go into the contralateral foramen of Monro. In these cases, after 1 hour of the tumor removal to the right foramen of Monro, we cross the midline, we go to the contralateral foramen, and we still discover some tumor into the left foramen of Monro that otherwise would have been left behind. And sometimes a good exploration of both foramen of Monro is very important to remove completely the tumor. It is an old case of papilloma of the choroid plexus, your typical papilloma of the choroid plexus. The foramen of Monro looks very small if compared to this very large tumor, but in fact, this tumor very easy to suck away only with the sucker. And in this case, we did more than 10 years ago callosotomy and transforaminal debulking. In this case, you can see the approach through the corpus callosum, and this is the tumor through the foramen of Monroe. It is very easy with this technique to suck the tumor out with your sucker after the biopsy, or with the cavitron if you prefer, and coagulating at the same time, and the tumor just follows your sucker. You remove the attachment, you cut it, and you can check at the end of the surgery that the third ventricle is completely free. This is part of the past. This is the post-operative CT scan of this patient. This is part of the past. Now the choreplexus of the third ventricle in our department are removed completely endoscopically. This is the most recent we did. The choreplexus papilloma of the third ventricle is completely removed through the endoscope with a cavitron. There's a small clot into the third ventricle, but with complete resorption, almost complete resorption only 10 days later. And the endoscopic transforaminal approach also is very, very important in the cystic craniopharyngiomas, as already shown by Mohamed El Beltaghi very nicely. This is an approach that we like very much. When we have the cavitron and we have the cyst, we just touch the cyst and we start to aspirate the liquid that is inside the cyst, and we can then continue to remove the tumor endoscopically for a very, very long time, removing all the floating part of the cyst wall that is inside the third ventricle. And so we can really have a very, very nice and almost subtotal removal of this tumor, only sometimes limiting our surgery to a single endoscopic procedure, leaving the part that is infiltrating the hypothalamus for radiotherapy, according to the conservative policy that has been nicely illustrated by Mohammed in the previous talk. This is the postoperative CT scan and MRI. You can see that there is a small attachment in the floor of the third ventricle, almost very, very good removal of all the floating part of the cyst and of the part that is below the floor of the third ventricle, and some remnant attached to the tuber cinereum, pre-op and post-operative. Transforaminal, we can also remove other tumors, like in this case an OPG at the first diagnosis, just to decompress the aqueduct and restore CSF pathways. But also, if you need to do complete removal, you can also remove a very significant and large and calcified tumor, like in this case. That was a low-grade glial tumor of the third ventricle, completely removed through a transforaminal endoscopic, purely endoscopic approach with the endoscopic cavitron. So endoscopic transforaminal certainly is a very important part. Then the interforniceal. Interforniceal also. Typical interforniceal remains only when a good cyst of the septum pellucidum is present. I have done a few cases without cyst in the past. I would not do that anymore because I think it is too dangerous procedure when the column is not separated by the presence of the cyst of the septum pellucidum. In this case, for example, of OPG in a neonate, you can see that the column of the fornix are very, very nicely separated by a cyst of the septum pellucidum. And so in this case, certainly the possibility of doing this kind of surgery through the between the trigons is possible. You can see here again the interhemispheric fissure. You can see the right and left callosomarginal and pericallosal artery in the same time, and the right and left cingulate gyri in a very nice anatomy. Here you can see the four arteries. Finally, a clear anatomical pattern, and then incision of the corpus callosum must be perfectly in the midline to open the cyst of the septum pellucidum. Here we are entering into the cyst of the septum pellucidum. We are opening more and more the cyst of the septum pellucidum, entering into the cyst and showing finally the floor of the cyst of the septum pellucidum very nicely with the right bundle of the fornix, left bundle of the fornix, and opening the layer that covers the tumor, and staying very far away from the right and left bundles of the fornix that are really very lateral in our field. And this is a very safe approach when there is a cyst of the septum pellucidum. Pre-op and post-op, this is an OPG and was sent to chemotherapy for the residual. Then the subchoroidal. Subchoroidal is a fantastic approach in order to remove tumors of the posterior third of the third ventricle, or tumors of the upper midbrain that is bulging into the third ventricle. And in this case, you can see the tumor of the third ventricle, the posterior third ventricle. It is very compressing the midbrain. There is a large foramen of Monro, but there is also a very large massa intermedia. You can see here. So with this large massa intermedia, through a transcallosal approach, our vision would be very limited for the tumor, and so we will be in very big trouble through a transforaminal approach. So we can imagine to do the pineal approach in this case, but if we consider the length of the choroidal fissure and then opening the choroidal fissure, we have a complete vision, very nice vision of all the tumor. In this case, we preferred to open the choroidal fissure and to do a transcallosal transchoroidal approach. This is the path of the transchoroidal approach, in transcallosal interhemispheric, transcallosal identification of the choroidal fissure, opening of the choroidal fissure, debulking of the tumor, and then reaching the final target, that is the inlet of the aqueduct. This is the identification of the pericallosal arteries. This is the identification of the corpus callosum, standard callosotomy, and this is how we do the transchoroidal approach, coagulating widely the choroid plexus. Below the choroid plexus, we identify here very nicely the taenia of the fornices. This is the part where the fornix adhere to the talia choroidea, and below it we can find the point where the right thalamus striate veins enter into the third ventricle, becoming internal cerebral vein. We dissect the taenia fornices on the left from the right internal cerebral vein on the right. Below we find the talia choroidea, and we open very widely the choroid fissure, and we identify the posterior pole of the tumor, and identifying both internal cerebral veins. Then we open the tumor and we remove completely the tumor very nicely through this approach. It's a very intriguing and long approach, but with the best possible exposure of the posterior part of the third ventricle. This is also usable in this kind of midbrain tumor bulging into the posterior third ventricle. This was a growing ganglioglioma, growing after a first partial removal to the fourth ventricle, and it was necessary to remove it completely. That was done through a subtranschoroidal approach. But this is also feasible in tumors of the thalamus that bulge into the posterior part of the third ventricle. In this case, for example, we can see that the tumor can be approached through the subchoroidal approach, keep staying very much away from the through this way, very much away from the corticospinal tract that is very lateral to the tumor. That is very nicely seen in this tractography reconstruction, 3D reconstruction, and we can see that through a contralateral transchoroidal approach, we were able to do a complete removal of the tumor without any neurological deficit. Possible complication, of course, are of all these approaches are diabetes insipidus, akinetic mutism, asectic meningitis, every kind of possible complication that you imagine. We are crossing so many structures, and we work in such a deep location through such a narrow corridor that every possible complication can occur. But these approaches, in experienced hand, can be done very, very nicely. On posterior approaches, I must remain very, very short because the time is not sufficient. Please remember that the posterior part of the third ventricle can also be approached through the classical occipital transtentorial approach and through the supracerebellar approach. In this case, for example, you can have the choice between the supracerebellar approach and through the infratentorial approach. In transtentorial approach, my preference usually is for the occipital transtentorial approach, who gives a very nice access to the third ventricle, greater ability to visualize the lesion in my hands. better visualization of the third and better anatomical orientation, no veins to be sacrificed, and no risk of venous infarction unless the surgeon divides internal cerebral veins. So in my hands, the occipital transtentorial should be preferred, but we can discuss about that for hours. Thank you very much for your attention, and thank you to all.
Thank you, Pepe. That was brilliant. I think we have heard and seen two great lectures from two giants of third ventricle surgery. I think the main takeaway messages that we have heard today is, as has been stated by many others, that preserving vascular function is one of the key elements. So I have a question that I would like to direct to both of you, and I think it's imperative whenever we try to attempt third ventricle surgery, especially in craniopharyngioma and anterior third ventricle lesions, that we must be very careful to identify the anterior cerebral artery and the communicating artery, which will lead us to define whether we're dealing with post or pre-chiasmatic lesions and their approach. Any comments on that, on how you do evaluate that, Mohammed?
When you have a pre-chiasmatic, so then?
Yes, the value of the anterior communicating artery as seen on the pre-op studies in order to determine your pathway and approach.
Oh yeah, for sure. When you see the anterior communicating artery in prefixed, usually have to work, or it's better to work through the corridors, which I have showed in the oculomotor triangle or opticocarotid, and the retraction of the frontal lobe and temporal lobe in some issues could injure the perforators when you retract before bulking that. So I prefer when you have this anterior communicating or prefixed chiasm, you just go filter the system, reduce the tension, work in the carotid, oculomotor, and opticocarotid triangle, start debulking, and then dissect the anterior communicating and start visualizing from the bifurcation backward with little retraction. So the most important thing is not to retract the frontal lobe back from the start before opening completely the whole sylvian fissure.
Thank you.
Adrian, I agree with you that the identifying the anterior communicating on the preoperative sagittal MRI is the probably one of the most important thing to do before deciding the approach. I think when you have, for example, also not only in craniopharyngioma, as Mohammed said, but also in OPG, when you have a very, very large OPG, it is really important to identify. Sometimes you have exophytic OPG, and identifying the position of the chiasm and of the optic pathways. If you don't have a visual tractography, it is the only way to do is to find the black spot of the anterior communicating, measuring from the anterior communicating to the tuberculum to understand what is your surgical corridor. And for me, this is probably the most important decision, the most important point to study to decide if I do the anterior interhemispheric or the transcallosal. Another important point, and very easy to identify, is the anterior commissure. When you have a tumor that is hidden anteriorly behind and anterior to the anterior commissure, in those cases, transforaminal route can be very tricky, and you can tend to forget or to leave without endoscope assistance, to leave some tumor anterior hidden by the anterior commissure through the foramen. Now with the endoscope, the risk is lower, but I think that the position of the anterior communicating and of the anterior commissure are the most important thing.
So also an additional trick for young trainees. Many years ago, I think Mohammed was also exposed to the experience in Boston. Michael Scott told me a very simple trick, and is that whenever you are performing a right terional craniotomy and you're right-handed, it's not the very same thing as whenever you're working through the left, because your dominant hand is at a completely different angle. So the position of the head should be turned even farther away, because your trajectories will change because of the fact that your non-dominant hand is now approaching through an opposite angle into the fissures and the cisterns down there. So always take that into consideration as well. Another thing, Pepe, is that I think your experience has been the same as ours, that in children, whenever you do callosotomies, even extensive callosotomies, we seldomly see disconnection syndromes. The younger, even for epilepsy or for tumor resections, I still have not seen the true disconnection syndrome that is described in adults, in kids. Do you agree with this?
Absolutely, absolutely. I must admit that I don't remember a real disconnection syndrome as reported in many cases of adults. We try to do the smallest possible callosotomy, but in some cases, of course, you cannot always achieve this when you have, especially giant tumors of the lateral ventricle. This can be difficult to limit your callosotomy because you really have troubles in dominating giant carcinomas or big tumors. So you are led to do larger callosotomies above 2 centimeters, above 2 centimeters and a half, and even in those cases, I don't see them.
There is a question here from the audience. I think I can answer to that. And it's, what is the experience with using Ommaya reservoirs and interferon alpha 2b? Do you use it, Pepe?
No.
We have used it for the last 15 years or so. I think it's very important that we use it mainly for primarily cystic, monocystic craniopharyngiomas. We insert an Ommaya. We aspirate it, and we first reduce the volume of the craniopharyngioma, and then we use 3 million units per dose, twice a week, or sometimes now we're using 5 millions just once a week until we reach 35 million. With this, we have seen in about 40 to 45% of the cases, they stop growing and they regress, and then you end up with this little popcorn within the cella, and they can stay like that for many, many years. But like, with craniopharyngioma, I think this is just delaying, and they will eventually restart growing later on. So I think it's a temporary measure, but it's one that has the advantage in some children of preserving growth and sexual differentiation until further on. Mohammed, whenever you have these residual lesions of craniopharyngioma, in your opinion, which is the best option of radiotherapy treatment, from all the things that are available today, from standard, LINAC, CyberKnife, Gamma Knife, proton beam? What is your take on that?
For proton beam, we don't have much experience. I just the 2 cases to Germany for proton beam, so I cannot assess yet the cranial for proton beam. But normally, we did some Gamma Knives. I had some complication after Gamma Knife with 2 cases coming back. One had early recurrence, and the other had a pseudoaneurysm developed after 1 year of the Gamma Knife. So the majority of cases was lead accelerators. This is the majority which I recommend to have it. And one thing is very important is the timing of therapy. With the radiotherapy immediately after the excision, within a month or 2 months after the excision, but not follow up, and we start the tumor start growing, giving radiation late had a poor control than giving early radiotherapy after. That's very important. And conformal and LINAC is the best. think there's enough experience about proton, but for gamma knife, I don't prefer. I have some complications from about 8 or 9 cases we sent for gamma. And
Adrian,
also
can I
the
ask a
recurrence
question?
rate in gamma knife is much more higher. Yes, Salman.
Yes, Mohammed. This is from residents because we are also telecasting on YouTube, and there's a question from YouTube. And the residents want to know, how do you decide which patients you're going to operate endoscopically? Which one would you do subfrontal approach? Which one would you do pterional approach?
Usually I do pterional approach or lateral subfrontal. That's what I'm used to. I have been trained as, in Yashargil Center on the pterional approach, and I still believe that all neurosurgical approaches could be summarized pterional and retrosigmoid, which you can do everything from. So this is not the matter, but what you trained to is what you should do, which means that some people can do a keyhole, like the keyhole for Bernitsky, and do this. Some doing pterional or subfrontal, all lateral subfrontal. But what you are trained to do is the best. So endoscope can help you to assess all the corners while using any of these approaches. It's exactly like to do a supracerebellar, infratentorial, or occipital transtentorial. It's the same, almost the same way. So I think the pterional approach, every neurosurgeon, and using the endoscope during the pterional would help you to get parts hidden in the third ventricle. And you can tailor it to lateral subfrontal orbitozygomatic. You can still widen it and use better exposure.
Sure, Pepe, your thoughts?
Yeah, I agree. I mean, it's true that what you know better, you feel better. The important is that during your training, you should be trained to do every possible kind of approach. Then during your career, you tend to prefer one approach to the other, but you should try to keep your mind always open. If for one patient, there is no lateral expansion. It's a purely interhemispheric tumor that goes interhemispheric subfrontal straight on the midline and then enters into the third ventricle. I think that removing this subfrontally or pterionally is not as good as doing an interhemispheric approach. Some surgeons prefer the interhemispheric translamina terminalis, especially in adults. I mean, we discussed about conservative treatment of craniopharyngioma in pediatric neurosurgery, but in most adult congresses, they all talk about how to remove the craniopharyngioma completely. It looks as if there are two different kinds of diseases, and most of the surgeons who do this kind of approach, certainly the pterional remain the standard, main gold standard, but most surgeons also go for the interhemispheric midline. That I don't like, but I know that in some cases for the patient is certainly better, especially when you need to go very low with your bone removal, because otherwise you have limitations in your upward vision. And I removed the central part of the orbital bandeau to have the best possible vision if the tumor goes very up behind the communicating artery.
Adrian?
Yes, I think one of the key points in these lectures is that compared to what was taught in the past, one needs to be very judgmental of how much tumor you should remove. And we, of course, as neurosurgeons, sometimes we have this ego that the lesion has to come out completely, but we can induce heavily damage on these kids. So if there is doubt that by removing a lesion, you're gonna rupture a vessel or injure a critical structure, it's better to leave a portion behind and then come back, especially in optic pathway tumors, in which basically we debulk and leave the capsule, and sometimes they stall for many years or regress. Salman, shall we proceed to the questions? You're muted, Salman.
Emad, can you show us the questions, please? Okay, Mohammed, do you want to take these, please?
Yes, pediatric craniopharyngioma are mostly of papillary type. This is false, because pediatric craniopharyngioma are mostly adamantinomatous type, and the adult craniopharyngioma are the ones which are papillary type. They are completely different. The other question is...
Next, please.
Endoscopic assisted microsurgery craniopharyngioma can detect hidden tumor under the chiasm. Yes, I have showed a video where you have introduced the endoscope after assessing the totally removed, and you find a small residual part under the chiasm. Pediatric craniopharyngioma can show apparent beta-catenin denoting aggressive form. That's true, because beta-catenin, when it is apparent, this indicates an aggressive form of cranio that recurs oftenly. And that's why we suggest giving therapy even after total removal when you have more than 10% apparent beta-catenin. Lastly, the conservative management of craniopharyngioma means biopsy and radiotherapy. This is false, because conservative biopsy in craniopharyngioma is not an accepted line of treatment. You should go for maximum safe debulking and radiotherapy. That's called conservative when you leave a small part attached to the hypothalamus or the undersurface of the chiasm.
Okay, so let's continue with the questions from Professor Shinali.
Okay, the anatomical structures encountered during a transcallosal approach are in the order A. Callosomarginal is the first one, cingulate gyrus, pericallosal arteries, corpus callosum, then septum pellucidum, then lateral ventricle, and all other solutions have some kind of anatomical inversion. So most of you have answered correctly. Congratulations. Transcallosal transchoroidal approach can be used in which of the following? Meningiomas of the lateral ventricles, clearly not. Tumors of the posterior ventricle, clearly yes. Midbrain tumors bulging into the third ventricle, yes. Posterior thalamic tumors bulging into the third ventricle, yes. So the correct answer is E. Very nice. Anterior interhemispheric translamina terminalis approach is indicated in some tumors of the anterior third ventricle, pineal region, pineal tumors bulging into the posterior third ventricle. This is clearly not possible, or certainly not indicated. Chiasmatic gliomas with a subfrontal extension, that is probably the best indication. Choroid plexus papillomas of the third ventricle, absolutely not. So the proper answer is A plus C, and a very nice collection of response. Very nice.
Well, I think we have today we have reached, I think.
Adrian, there is one question. Excuse me. There is one question. The very last question is how to enlarge the foramen of Monro if it is narrow. This is very important. The transchoroidal, in fact, the transchoroidal approach can start from anteriorly. It is unfortunately, due to the time, I could not show this clearly enough, probably. But when you go to the attachment of the choroid plexus, to the point where the choroid plexus enter into the third ventricle, at that point, coagulating the anterior septal vein, you can cut the anterior septal vein, and then you can start to enlarge the foramen of Monro posteriorly. So the transchoroidal approach, in fact, is an enlarged transforaminal approach. You can enlarge posteriorly, of course, the foramen of Monro. You cannot enlarge the foramen of Monro anteriorly. This is absolutely impossible because you would cut the fornix. But you can enlarge the foramen posteriorly by performing a transchoroidal approach.
Thank you, Pepe. So I was just about to say that we have reached today almost 230 to 250 participants. I think this was mainly attracted by the two main speakers in this series of lectures, two giants in brain surgery. So I really like to thank you both for spending your time on this Saturday. Imad, can we show the slide for the upcoming, for the next week? Okay, so the next Saturday lecture will be given by my former professor, Dr. Tadanori Tomita, who will speak about pineal region surgery and especially his transtentorial and subtentorial approaches to the pineal region surgery. And then we also have Sergio Caballero, which has an incredible lecture on brainstem tumor resection and his surgical corridors to the brainstem. I think these are two very exciting lectures to be heard for everyone. And I would like to invite you all to continue participating in this series of lecture. Again, thank you, Mohammed. Thank you, Giuseppe, for this extraordinary experience. Salman, do you want to add something?
Yeah, I think brilliant. Again, I'd like to thank both the speakers who were great and all the participants who joined us for this wonderful session. Can you switch on your videos? We're just going to have a group photograph, which we do at the end of every session that we do. Can you switch on your videos, please? Thank you. Everybody. I'm sure we all learned loads today. Brilliant, and everybody can smile. Imad, let us know when you're done.
Yes, sir, 1 minute. Yes, sir, it's done.
Brilliant. I think the reason more people are interested in these lectures is because you are showing them the tricks and the tips coming from the giants. And that's the reason more people are interested. Everybody wants to hear these because these are really essential bits that we need during these surgeries. So thank you all. Looking forward to see you next Saturday. Okay, cheers. Bye-bye.
Bye-bye.
Thank you. Thank you, Salman. Thank you, Adrian. Thank you, Billy.